Thanks, James. Today I'll present my case of a 44-year-old woman with chronic phase CML who was diagnosed 4 years ago. At the time, she was offered frontline therapy with nilotinib, 300 milligrams twice daily. She had a great response. In fact, at 3 months, she had 3 log reductions already. And at 12 months, she had 4 log reductions with MR4 and maintained her treatment with good tolerance for 4 years. When recently she started complaining of fatigue and not feeling well, that prompted her physician to perform a CBC, and the CBC done showed a loss of CHR with hyperleukocytosis and left shift, thrombocytopenia, and anemia. They did a PCR on peripheral blood, and the PCR showed a ratio of 100% on international scale. This is what we have from outside, and this woman, with this workup done, she was offered dasatinib therapy at a dose of 100 milligrams per day. And then she took her treatment, and then 3 months later on, she had a CBC done showing no response with the hyperleukocytosis still of 137,000, anemic, hematocrit 25%, hemoglobin of 9, and then still thrombocytopenic. Repeated PCR at 3 months showed a ratio of 90% on international scale. At that time only, she had the bone marrow done, and the bone marrow showed hypercellularity with 20 out of 20 Philadelphia positive metaphases. No, at this stage, she did not have transformation because the marrow blasts were below 20%. She had a Sanger sequencing done looking for mutations, and unfortunately, she was identified to have the T315I mutations known to be resistant to all TKIs. At this stage, she was referred to us for further management, and that's why I'm presenting this case here today at our tumor board to discuss the best approach for this patient.
Thank you, Elias. Adam, do you want to tell us kind of, when we talked about this a little already, but our options for mutational testing and whether or not maybe at this point a bone marrow biopsy would change our approach or your approach as a hematopathologist?
So I think she's got clear indication of a need for mutational testing based upon that she now presents in what most people would call accelerated phase with more than 10% blast. So that's an indication for mutation analysis. As we discussed earlier, the current technology that's preferred for doing mutational testing is the relatively insensitive Sanger approach, in which you need 10, perhaps closer than 20% mutations or cells with mutations to pick up the mutation. We've discussed that there are more sensitive technologies for mutation analysis, such as next-generation sequencing and other approaches that could be used. Whether it's necessary in this day and age to do more sensitive testing, I think remains unresolved. Clearly, the mutation she has, as mentioned, is a particularly bad one, the gatekeeper mutation of T315I, which will almost certainly impact her therapy. The need for a bone marrow, of course, generally speaking, once a patient is being monitored for CML, for the most part, bone marrows are required less frequently, perhaps, than peripheral blood monitoring. As we know, you can do RT-PCR, quantitative RT-PCR to monitor in the peripheral blood. There's no need to do marrows for that. But the reason for doing a marrow in this patient is, as a diagnosis, to improve your yield of metaphases and to look for cytogenetic evidence of clonal evolution.
I would add to what Adam mentioned is this woman at 3 months, when she failed nilotinib, should have had the bone marrow done because she had feature of transformation obvious on the blood. She could be in a blast phase disease, and then we missed it because she had a PCR of 100% or she's resistant and go for single agent therapy. Should we have done a bone marrow at 3 months and she had transformation, maybe I would offer a different approach. I would have chemotherapy and TKI and maybe offer transplant. So I think we should repeat a bone marrow every time we have resistance documented, not only relying on PCR, because yes, we need the cytogenetics, but we need as well to look at the other criteria of transformation, among them the blast in a bone marrow. As well, look at the immune phenotype too.